Hello everyone, my name is Marietta Charakida. I'm a senior lecturer and consultant in fetal and pediatric cardiology. Today we are going to discuss about fetal cardiac function, and I'm going to give you a brief overview of conventional and novel tools available in the Canon machines. Some abnormalities in ventricular function can be seen with naked eye. In the first clip you can see a typical case of critical aortic valve stenosis. The left heart is dilated, there is reduced contractility and evidence of endocardial fibroelastosis. In the second clip, the pathology is on the right side of the heart. There is tricuspid valve regurgitation and there is reduced right ventricular systolic function. These findings will indicate the presence of pulmonary atresia with intact ventricular septum. In the last clip, the pathology is on both sides of the heart. There is cardiomegaly, and these findings would suggest the presence of myocardial problem, and the most likely diagnosis is going to be cardiomyopathy. However, apart from these severe cases where cardiac failure is imminent and the outcome is most likely reversible, we can have subtle fetal cardiac functional changes that we need specific tools to be able to identify them. EMOD is an old technique which has been used to assess left ventricular systolic function. We can use EMOD on the fetal transverse views to assess the difference between the end systolic to endosystolic ventricular diameters, and from that we can calculate ejection fraction. We need to remember that this parameter is an indicator of radial function of the heart. EMOD can also be applied in the long axis of the heart to calculate the tricuspid annular displacement, commonly referred to as Tapsy, and from the left side the mitral annular displacement, known as Mapsy. We can use conventional inflow Dopplers to assess diastolic function. Here you can see that we can measure the early diastolic filling and atrial contraction and calculate the E to A ratio, which reflects ventricular relaxation. We need to remember that this parameter is affected by respiratory and corporal movements, but also from changes in the fetal heart rate. We can use inflow Dopplers to estimate the timing intervals, the isovolemic contraction and relaxation time, and we can present them independently or part of a composite parameter, the myocardial performance index, which is a sensitive parameter of early fetal cardiac dysfunction. Tissue Doppler imaging is a novel methodology. The color tissue Doppler encodes the mean velocity of the myocardium. The myocardium is colored and the blood pool is black, and we can use pulse tissue Doppler to sample myocardial velocities at a given point. From this technique, we can also calculate the timing intervals in the same way that we did in the pulse Doppler. 2D Speckle tracking is another novel method that we can use to assess myocardial or more accurate endocardial deformation. This technique can be applied in the left and the right side of the heart, and this will allow us calculation of segmental as well as global longitudinal strain and strain rate. To conclude, I would like to finalize my talk by saying that by using these techniques, our group and others have been able to detect early fetal cardiac functional changes in a variety of conditions, including gestational diabetes, preeclampsia, fetal growth restriction, and twin-twin transfusion syndrome. However, it remains to be established how these early fetal cardiac functional changes relate to outcome and whether they persist in postnatal life. Thank you so much for your attention.